In this lecture, we will discuss right bundle branch block, including its pathophysiology, EKG features, potential causes, and clinical significance. If you recall, the normal electrical conduction system of the heart starts at the SA node in the right atrium. Okay, so let's just review our conduction system. So here's our sinus node. Okay, then we have our internodal pathways that come here to our AV node. Okay, and then we have our His bundle. Our His bundle then splits off into a left and right bundle branch. Okay, so on the left side, so here's our left ventricle. This is our right ventricle. Innervating our right ventricle is our right bundle branch, and then our left bundle branch on the left side. Then there's a left anterior fascicle and a left posterior fascicle. Okay, and then both these fascicles in the right bundle branch end in the ventricular Purkinje fibers, which innervate the cardiomyocytes. So what we're going to be looking at here is a right bundle branch block. Okay, when the right bundle branch is blocked. So what we have here, and you can see it here in red, is that our right bundle branch at this point is being blocked. Okay, so nothing can conduct past it. Now, if the electrical impulses generated by the pacemakers in the atria or the AV node suddenly hit an obstacle in their normal conduction pathway, they will not be able to proceed to the cells downstream from the block. Instead, the impulses will travel by direct cell-to-cell transmission, and this is a much slower and chaotic means of innervating the myocardium. It results in a wide and bizarre QRS complexes that are often seen in bundle branch blocks. Remember that premature ventricular contractions, or PVCs, also result in wide, bizarre QRS complexes. The difference here is that the premature ventricular contractions is aberrantly conducted from its inception, from the start of it, okay? While the bundle branch block is normally conducted until it hits that block. And it is the initial component that gives bundle branch blocks two main appearances with minor variations, the right bundle branch block and the left bundle branch block patterns, okay? Here we're going to focus on that right bundle branch block pattern, okay? So what I'm saying here is that just so you're clear, when we talk about PVCs, we're saying that it's coming from some ectopic focus here in the ventricle, so it's right from the start of it, it's already conducted aberrantly. Here, with our right bundle branch block, let's say it starts in the sinus node, so everything's normal as it conducts through, it's going down and then eventually encounters our block here within that right bundle branch, okay? So let's look at what happens with right bundle branch block. When there's a block in the right bundle branch, the impulses gets transmitted normally by the left bundle to most of the left ventricle. However, the impulse to part of the intraventricular septum in the right ventricle is delayed because of cell-to-cell depolarization imposed by the block. Okay, so what I'm saying here is, again, we have normal conduction coming down our path, and then it continues to the left side, so all the left ventricle here will depolarize normally, okay? And then eventually, because there's a block, then we'll have this last vector, all the impulses from the left side then coming to the right side to depolarize this, okay, to the right side, the right ventricle. So notice that green arrow, that's the last vector. That's the later vector because it's coming from the left side. It's going from left to right, okay, across, coming from the left ventricle. And this slow cell-to-cell depolarization results in slower depolarization time, which manifests on the EKG by a prolonged QRS interval to 120 milliseconds, which is 3 small boxes or more. This prolongation is key for any complete bundle branch block. Now, under normal circumstances, it is the left ventricle that gives rise to the vector that accounts for the QRS complex. However, in right bundle branch block, the late innervation of the septum and the right ventricle creates this new, slower vector that is unopposed by the vectors from the left ventricle. Okay, so just as we're saying, let's just review it again. Okay, so it's coming, everything's coming down normally. Okay, we go to the left ventricle because we can't, everything's blocked on the right side, so the left ventricle depolarizes normally. Okay, and then eventually, coming later, we have this slow depolarization vector that's coming from the left side to the right, okay, slowly making its way to the right side to depolarize the right ventricle, okay, and it's an unopposed vector because the left ventricle is already depolarized, so this is a slower one. Now this new vector produces a variation in the normal EKG pattern, and we get a new wave called the R prime wave, okay, and this appears in the right precordial leads V1 and V2 because there's a new vector from the slow conduction through the interventricular septum and the right ventricle heading towards those leads. This this QRS complex is also called the RSR prime complex. Okay, you may hear it referred to as the rabbit ears or M-shaped complex. The R prime also tends to be greater in amplitude than the initial R wave. Okay, so if you imagine here, we have this vector. Let's just erase this here. We have this vector that's coming from the left side to the right, okay? And remember, our right ventricle is the most anterior portion of the heart. So if it, imagine these are heading towards leads V1 and V2, okay? So because it's coming towards those leads, we're going to see this initial, this R prime, we call this the RSR prime complex, okay? So RSR prime, and you can notice that it kind of looks like these rabbit ears, people call them, okay? Or an M-shaped complex, all right? And you can see that here. And remember that the R prime wave, that second wave here from that this vector, the green vector, is heading towards those leads, so it's upright, and it's going to be greater than the initial R wave, okay? So that's one thing to notice, that R prime has a greater amplitude. Notice this compared to the initial R wave. Okay, that's one thing to note. So I'll just erase that so you can see it. Okay, so this is our rabbit ears, or the M-shaped complex, coming from this vector that's heading towards those leads. And since we are here, a QR prime pattern that we can see also in these leads, the right precordial leads, may suggest an anteroseptal MI. Okay, so sometimes when we talk about infarctions, we'll see that Q waves can develop. Okay, and if you have a Q wave, what you'll have is a complex that has this downward Q wave. Okay, the initial negative deflection after our P wave, so this is a Q wave, and then this R prime wave, okay? And because you have that infarction in that early V1 and V2, the anteroseptal region, okay, we won't have that initial small r, okay? That's a little bit more advanced, but I think when we get to infarctions, you'll start to understand this right here, okay? So again, notice in V1 and V2, you have these RSR prime pattern, okay, that rabbit ear in those leads. All right, so there's also a slurred S wave that can be seen in the left lateral heart lead. So that's leads 1, AVL, V5, and V6. And this slurred S wave is from the slow transmission of this new vector away from those leads. Okay, so now imagine these leads. They're V5 through V6, 1, and AVL. So again, here they are on the EKG, 1, AVL, V5, and V6. I put these here so that you can kind of get oriented to when you look at a 12-lead EKG where they're appearing. Okay, here's V1 and V2, and then our lateral leads here in blue, 1, AVL, V5, and V6. Okay, and if we looked at them here, remember we have AVL as our high lateral lead. Lead 1 is here, and then we also have V5 and V6 as our left lateral leads. Okay, and lateral meaning the left ventricle is what we're talking about with the lateral portion of the heart. Okay, and we'll notice that this green vector is heading away from those leads. Okay, and that in such cases, because we have that vector heading away, we're going to see a negative deflection. And this is that slurred S wave, which is this portion down here. Okay, and you'll notice it in all these leads, that slurred S wave. Okay, note that the slurred S wave should have a longer duration than the R wave in the lateral leads, often by at least 40 milliseconds, as it represents that new, slower, unopposed vector. Now, another finding with bundle branch blocks is discordance. In other words, the ST segment and T waves are directed in the opposite direction to the main QRS vector. Okay, so again, discordance is when the ST segment, okay, so if we look at V1 and V2, we'll draw our baseline here. Okay, notice that our ST segment is depressed, so we have ST depression, and we also have this T wave here that's inverted, so T wave inversion. But notice that the main QRS vectors are mostly positive. Okay, so we have positive main QRS vector, and then these are going in the opposite direction. We call that discordance. Okay, and the same thing is true with our end vector here. Okay, notice that this main vector at the end of our QRS complex is going downwards. Okay, and then our ST segment, when we draw our baseline, notice it's elevated and an upright T wave. Okay, so we call, again, this is called discordance. Now, if the ST segment and the T wave went in the same direction as the main QRS vector, that's called concordance, and it may actually suggest underlying pathology such as myocardial ischemia. So those are the main EKG criteria for right bundle branch block. I hope this is all making sense. Now you should note that if all these criteria are met except for the prolongation of the QRS interval, then this is considered incomplete right bundle branch block. In other words, it is considered complete right bundle branch block only when all the criteria are met, including that prolonged QRS interval. Okay, let's end with looking at some causes and the clinical significance of right bundle branch block. So some causes include idiopathic right bundle branch fibrosis or degeneration, congenital heart disease such as atrial septal defect, ischemic heart disease secondary to coronary artery disease, acute cor pulmonale such as in the setting of acute pulmonary embolism, COPD, right ventricular hypertrophy from the stretching, and as the right ventricle gets bigger it could affect and damage that right bundle branch. Cardiac surgery is a cause which can cause transient or even permanent right bundle branch block, and percutaneous coronary intervention or PCI. This can cause transient right bundle branch block as well. Now, luckily, right bundle branch block has been shown to not be correlated with any adverse outcomes in asymptomatic patients. However, if there's new onset right bundle branch block in the setting of chest pain, it may suggest left anterior descending artery occlusion or LAD occlusion. And if there's new onset right bundle branch block and your patient has acute shortness of breath, you should be thinking of possible pulmonary embolism. Okay. And lastly, right bundle branch block does not affect the diagnosis of ischemia or infarction, but it does limit the diagnosis of right ventricular hypertrophy. Okay, and we'll see with left bundle branch block, this does actually affect the diagnosis of myocardial ischemia or infarction. All right, let's briefly review what we discussed before we end. So again, right bundle branch block is an anatomical or functional dysfunction of that right bundle branch. Okay, the block causes the impulse to travel down the unobstructed left bundle branch block or bundle branch first, and then we have slow cell-to-cell depolarization from the left to the right side. Okay, and because of that we get that wide QRS because of the slow cell-to-cell depolarization. We get the new R prime wave in the right precordial leads V1 and V2, and the slurred S wave as this vector heads away from these lateral leads. Okay, we talked about the EKG criteria. If it's prolonged, meaning if it's 120 milliseconds or greater, we call that a complete right bundle branch block. If it's less than 120 milliseconds, that would be considered incomplete. Okay, that's how you differentiate complete versus incomplete. Okay, now in the right precordial leads V1 and V2, we're going to see those rabbit ears or the M-shaped waves where we have those RS/R prime patterns. Okay, and sometimes you may actually not see that S wave going below baseline. Okay, so notice here our S wave, this one here, is actually going below baseline. Sometimes you may see it stopping here. Okay, so that's sometimes seen as well. And remember that the R prime wave has a greater amplitude than our initial R wave. Okay, and if you see this a QR prime pattern, okay, in the anteroseptal leads V1 and V2, that may suggest an anteroseptal MI as well. Okay, remember that right bundle branch block does not affect the diagnosis of ischemia or infarction. Now in the left lateral leads, V5, V6, 1 and AVL, the S wave will have a greater duration than the R wave, okay, and we'll see those slurred S waves, okay. So that's one thing, the slurred S waves as the vector heads away from those leads, okay. And then remember, discordance is common and is normal in bundle branch blocks when the ST and the T wave are going in the opposite direction of the main QRS vector. Now concordance, we said, can suggest pathology such as myocardial ischemia. Then we went through all these causes and clinical significance. Now just to review this, remember 1 AVL and V5 and V6, we'll see those slurred S waves. So here's 1 AVL, V5, V6, those slurred prolonged S waves, okay, and then V1 and V2 are right precordial leads, the rabbit ears or the RS/R prime complexes. Remember, we're looking, the things that are affected are the later portion, the terminal vector. Remember, this green vector here is that later portion of the right ventricle being depolarized, so everything at the end is affected, the R prime, the slurred S wave. So all the end is where our terminal vector is heading, represents the area that has been affected. Well, that's the end of this lecture. We discussed right bundle branch block, including its pathophysiology, EKG features, potential causes, and clinical significance. I hope you learned something.